imaging has been very successful in a very interesting field of research in the last few years, vis-a-vis the very great success of JACC cardiovascular imaging. Thus, let's talk about what's happening here at ACC 16, and I'm with Dr. Sanjiv Kaul, who is an MD and the Distinguished Professor of Cardiology and Professor of Medicine and Radiology and the CEO of Knight Cardiovascular Institute and an Associate Dean, I should say, at Oregon Health and Science University. First off, thank you very much. I know you're a pioneer in cardiovascular imaging, and especially in contrast echo and nuclear cardiology. Here at this meeting, you're involved in a learning lab. Tell me about that.
So, Bracco Diagnostics has brought out a new contrast agent. This is the first new contrast agent, ultrasound contrast agent in 12 years. And they are trying to educate consumers, physicians, cardiologists on its use. So what they have done is they've asked people like myself and others who have experience to donate cases for their learning lab with case histories. And it's a case history based discussion for 45 minutes where first of all we talk about the indications, FDA approved indications, contraindications, safety, and then after that we go right into case after case, and it's interactive. So I'll put our case without contrast, ask them what it is, and then obviously the cases are designed so that they're going to be wrong. And then we put in contrast after that into the same patient, and then the right diagnosis comes up.
Now you're using sulfur hexafluoride lipid type A microspheres that can help improve image quality in patients with suboptimal echoes, correct? So this was introduced in the US just within the last year.
Yes.
For contrast performance, enhanced performance. Where is it used specifically? What's its approved indication?
Okay, it has a long history. Quite frankly, it was one of the earliest contrast agents developed. It was developed by Bracco in Geneva. We did animal studies, we did phase 1 studies, we did phase 2 studies in the early, more than 15 years ago in the US. Then the company made some kind of decision and started developing it as a phase 3 studies in Europe. And it's been used in Europe ever since. A year ago, they decided to bring it to the US. And so they brought it to the US now for LV cavity opacification, which is basically suboptimal echoes. They just got another indication approved for a liver.
Oh, wow.
Because there are very small liver nodules that are cancerous that are better seen with contrast than with MRI. The Japanese use it a lot and they've proven that. So this was an indication they brought it in, the general radiology indication. And now they are trying to get one for stress echo. Because in actual practice, 30% of all stress echoes utilize contrast. It's an off-label use. But they want a label use so that we can use it with stress echo. Because with the huffing and puffing and the lungs moving around, the pictures are so awful. And if you can see the endocardium better, you make a diagnosis rather than saying if, but, therefore, that kind of stuff.
Right. In terms of where is imaging going in the next few years? As I said in the open, imaging has been just one of the most exciting areas in all of cardiology in the last few years. Look ahead for the next 2 or 3 years.
Yes, I'll tell you where imaging is going, or where it should go at least. We started with structure, if you remember, right? X-rays, CT. Then we went into function, especially in cardiovascular. Function was very important. Dynamics was very important. Left ventricular function was important. Doppler was very important, quantifying valvular stenosis and regurgitation. But where we are really now going to go is into the biology of disease. So we are going to do molecular imaging, phenotyping biology, like doing a histochemistry of the heart non-invasively. Whether it's MRI, whether it's PET, whether it's contrast echo, these techniques will give us a huge amount of biological information layered on top of structure and function. So we can treat people and see if there is a response. Now, classic example of this, a rather crude example, is FDG for PET. So for cancer, it's used for staging, and then it's used for how cancer is reduced. But it's just based on oxygen utilization of cancer. It doesn't tell us which type of cancer, but the next generation is going to tell you which type of cancer. Yeah.
That's exciting. I mean, you've written quite a bit about handheld ultrasound, including a paper I should mention in JACC Cardiovascular Imaging. One question that gets asked is it time to discard the stethoscope?
Of course.
And you've had some wonderful responses to this, so let's talk about it for just a moment.
You know, seriously, it's an icon. It's an icon.
Absolutely.
And every physician will tell you they can't hear significant eccentric mitral regurgitation murmurs. They are bad at S3. They cannot separate by physical exam innocent versus non-innocent murmurs.
Right.
They cannot tell LV function unless the heart is huge. So why do we keep on pretending? Seriously, you know, why do we pretend? Why don't you say, this is a 200-year-old technology, it's a tube of air. It's an indirect way of listening to somebody's chest.
Hello.
Yeah. Why don't we just use something small? We use our iPhones, don't we?
Yes.
Use something small, put it on the chest, share it with the patient. It's a great experience for the patient too. And that's where it's going to go. Medical school, 40 medical schools are now introduced handheld ultrasound in physical examination curriculum. And where do you think the students gravitate? Not to the stethoscope.
But the pictures of doctors, they're not going to be able to wear one of those around their shoulders, so it's going to look silly.
We could design it with something. I'm wearing that badge around my shoulder. I could be wearing something like that.
I guess the last thing is, it's got to be fun. I mean, with what's been happening in the last few years, you must be having a good time.
Technology has been so amazing, you know. So there are two things, engineering and technology. And the other thing is the imagination of the physicians, that why don't we go from structure to function to histopathology? Why don't we go into more types of phenotyping? And I think both in science and in clinical care, the more depth phenotyping we do with imaging, the more value imaging is going to have.
Congratulations, first off, and it is great fun to talk to one of the pioneers in this, and the fact that you're still having fun with it is very encouraging.
Thank you.
And for a variety of coverage from ACC 16, please check out CardioSource World News and CardioSource World News Interventions, where I'm Executive Editor Rick McGuire.